If you are joining us today, you are likely someone operating right at that intersection of clinical practice and systemic analysis. You don't just want to know what the global health indicators are.
Right. You want to understand the structural mechanics actually driving those indicators.
Exactly. So today, our structural spine is Chapter 9 of the Oxford Textbook of Global Public Health. It's titled, Reducing Health Inequalities in Developing Countries. And just to be clear up front, this is not, it's not a summary.
No, definitely not. This is really a conceptual companion piece. It's designed to be engaged with right alongside the text. We are going straight into the architecture of inequity.
How it is built, how it is measured, and practically how a health system engineers a way out of it.
That's exactly the framework we need here. We are moving way beyond just, simple memorization of demographic data. We need to actually recognize the patterns of systemic vulnerability.
To build those clear conceptual frameworks.
Exactly. Mapping how a distal structural risk translates into a proximal exposure, which then drives a clinical outcome. Because if we don't understand the mechanisms of that cascade...
Any public health intervention we design is going to be fundamentally superficial.
Spot on.
So let's ground this immediately with a metaphor that runs through the core of this entire field. Think of public health as upstream river engineering.
I love this analogy. It perfectly captures the operational shift.
Right. So when you are working in a clinical setting, say an emergency department or a rural clinic, you are essentially pulling drowning people out of a rushing river.
Yeah.
You are deploying immediate life-saving interventions.
You intubate, you push antibiotics, you perform the emergency cesarean.
And that is absolutely vital. But public health equity is the discipline of walking miles upstream to investigate the structural integrity of the bridges.
Yes. It's asking why the guardrails are missing in specific neighborhoods and why certain populations are being systematically pushed into the water in the first place.
Which brings us to a really critical distinction, especially when we separate the concepts of equality from equity.
Right, because they are not synonyms. Equality is a downstream intervention. It is throwing a standard one-size-fits-all life jacket to every single person in the river, assuming everyone is fighting the exact same current.
But the reality is much more complex.
It is. Equity requires the analytical rigor to recognize that the river's current is manipulated. Some groups are caught in violent rapids due to historical and economic disadvantages, while others are floating in calm waters.
So true equity isn't just handing out life jackets.
Exactly. It's redesigning the riverbanks entirely. It is altering the social determinants of health to protect vulnerable populations long before they ever reach the edge of the water.
Redesigning the riverbanks requires us to look at the macroeconomic policies that shape them. Now, I think it's important to establish our operational parameters for this discussion right now.
Good idea. The source material does analyze some highly sensitive macroeconomic models.
It does. It touches on the impacts of neoliberalism, market liberalization, and historical political systems. So for you listening, please know we are examining these policies strictly through the lens of their measurable epidemiological outcomes.
We are evaluating them purely as mechanisms of health and disease.
Right. Analyzing the data on morbidity, mortality, and access to care without adopting any ideological stance. We're just following the textbook's data.
Absolutely. The data is what matters, and the data forces us to start by rigorously defining our terms, specifically the divergence between health inequality and health inequity.
The World Health Organization maintains a very strict operational boundary here, right?
They do. Health inequality is just a descriptive statistic. It is simply a measurable difference in health status or the distribution of health determinants between different population groups.
So if Group A has a higher incidence of tuberculosis than Group B, that is an inequality.
Exactly. It's a statement of statistical variance, nothing more.
Right, but inequity introduces a normative judgment based on the etiology of that variance.
Yes. If that difference in TB incidence isn't just some random statistical cluster, but is actually driven by factors that are avoidable, unfair, and remediable.
Like, say, Group A is forced to live in unventilated, high-density informal settlements due to discriminatory housing policies.
Exactly that. Then that inequality is formally classified as an inequity. Inequity is an inequality that stems from a systemic failure or an act of injustice that society actually has the capacity to fix.
And this is where the textbook integrates some really foundational philosophical frameworks to justify public health action. It heavily references Amartya Sen's capability approach.
Sen is crucial here. As a Nobel laureate in economics, he argued that development shouldn't be measured purely by GDP, but by what he called freedom from deprivation.
Viewing health not as a commodity to be purchased.
Right, but as a fundamental capability that allows a human being to exercise their freedom. I mean, think about it. If a person is crippled by preventable disease or lacks basic nutrition, they're entirely deprived of the capability to participate in society.
Regardless of how fast the nation's overall economic growth is rising.
Precise.
The text also layers in John Rawls and his 1958 principle of justice as fairness.
Oh, the veil of ignorance.
Yes, that thought experiment is brilliant. You have to design a society without knowing what socioeconomic class, race, or gender you will be born into.
And Rawls argues no rational actor would design a system where basic survival depends on immense wealth, because you might end up poor.
Exactly. His framework essentially argues that a society's institutions are fundamentally unjust if they don't secure basic health and education for absolutely everyone.
And those philosophical underpinnings, they aren't just academic, they are highly practical. They provide the actual mandate for the progressive health programmer.
Also,
Well, if health is a human right and inequity is anathema to socioeconomic well-being, then intervening in the social determinants of health isn't just an option. It is an ethical and operational imperative.
we are no longer permitted to view poverty simply as an unfortunate backdrop to clinical medicine.
Right. Poverty is the primary pathogen.
To see the lethality of that pathogen in its purest form, we have to look at the historical baseline. The text points to Edwin Chadwick's 1843 inquiry into the sanitary condition of the laboring population in Great Britain.
This wasn't abstract philosophy at all. Chadwick actually went out and gathered the raw mortality data.
And the stratification he found is just staggering. Listen to these numbers. In Liverpool, the average age of death for gentry and professional persons was 35 years. For laborers, mechanics, and servants, the average age of death was 15.
A 20-year survival gap based entirely on occupational class, living in the exact same city.
And we have to really look at the mechanics behind that average age of 15.
Yeah, it doesn't mean laborers were living healthy lives until their mid-teens and then suddenly dropping dead of old age.
No, an average life expectancy of 15 is indicative of astronomical infant and child mortality rates, pulling the whole mean downward.
It points to a complete lack of sanitation, rampant enteric diseases like cholera and typhoid in these high-density tenement housings.
And the brutal physiological toll of unregulated industrial labor on developing bodies. In Bath, the numbers were different, but the gap was identical. The gentry lived to an average of 55, while the laborers died at 25.
It's a 30-year penalty for being poor. But what is really crucial for modern public health practitioners to extract from this historical data is that the gap isn't binary.
Right, it's not just a massive chasm between the ultra-rich and the ultra-poor. The text highlights the concept of the relative social gradient.
The social gradient is perhaps the most vital epidemiological pattern to recognize in this whole field. Health outcomes track continuously across socioeconomic status.
So if you plot income or class on the x-axis and disease prevalence on the y-axis,
you don't see a step function. You see a continuous gradual slope. The people in the middle income bracket have worse health outcomes than those at the very top, and the people slightly below the middle have worse outcomes than those in the middle.
the gradient affects the entire population.
It's entire.
Which means you can't solve the problem by only targeting the extreme bottom percentile. The gradient implies a systemic exposure. So what is the actual mechanism driving that continuous slope? Because it's not just absolute material deprivation. Middle-class people generally have enough food and shelter.
It involves relative deprivation and psychosocial stress.
The psychological toll.
Yes, the lack of autonomy in the workplace, the chronic stress of financial insecurity, the unequal distribution of societal resources like safe spatial locations and educational opportunities.
All of that triggers chronic allostatic load.
Precisely. That continuous activation of the stress response system drives up cortisol, it increases systemic inflammation, and it massively accelerates the pathogenesis of cardiovascular diseases and metabolic syndromes across the entire gradient.
Chadwick's data catalyzed the Public Health Act of 1848.
Right.
But even with over a century of sanitary and medical advancement, this social gradient stubbornly persists globally today.
It does. And if the gradient is a systemic feature, not just a bug, then tackling it requires global architectural shifts.
The text traces the modern blueprint for this back to the 1978 Alma-Ata Declaration. This formalized the concept of primary health care, or PHC.
They called for health for all. It was an attempt to shift the focus away from these expensive urban curative hospitals
Toward community-based, preventive care that addressed broader social and economic determinants.
Alma-Ata was a monumental conceptual shift. It explicitly stated that health requires action from social and economic sectors, not just the health sector alone.
However, the operational reality of the 1980s decimated that vision. The text notes that adverse economic conditions in developing countries, compounded by the global economic downturn and the debt crisis, led to the imposition of structural adjustment programs,
Many developing nations were forced to drastically cut their public spending, including their health and education budgets, just to service external debt.
which completely stalled, and in many places actually reversed the progress envisioned at Alma-Ata.
Right. Fast forward to the Millennium Development Goals, the MDGs, targeting 2015.
The text evaluates this period pretty bluntly. Despite a massive influx of global funding and vertical disease programs like those targeting HIV, TB, and malaria, the prospect of achieving the broad MDGs was bleak.
Because the underlying health systems remain fractured. Throwing money at a specific disease doesn't fix the inequity in the system that's supposed to deliver the care.
Which is exactly why civil society initiatives like JALI, the Joint Action and Learning Initiative on National and Global Responsibilities for Health, began advocating for a framework convention on global health.
They recognize that fragmented, disease-specific activities, while absolutely saving lives in the short term, completely fail to reshape global health governance.
Or provide reliable, sustainable funding for comprehensive health systems.
Exactly. And this realization culminated in the establishment of the WHO's Commission on Social Determinants of Health, the CSDH, in 2005.
The CSDH framework is the operational core of this chapter. It is built on 3 massive pillars designed to provide context-specific advice for dismantling health inequity. So let's dissect Pillar 1, improve daily living conditions.
Pillar 1 requires a strict life cycle approach. You cannot wait until adulthood to address daily living conditions. The biological die is cast much, much earlier.
Promoting equity begins at, or even before, conception.
Yes. The nutritional and physiological status of the mother during pregnancy is the starting line. Once born, the infant enters a physical, social, emotional, linguistic, and cognitive milieu that dictates their neurodevelopment and immune function.
Mechanically speaking, we're talking about epigenetics and early childhood development.
The text makes it very clear that these early exposures determine the individual's propensity later in life to conditions ranging from obesity and malnutrition all the way to mental health disorders and cardiovascular diseases.
So the interventions absolutely must be front-loaded.
This means universal coverage of high-impact child survival interventions, access to skilled birth attendants to prevent intrapartum hypoxia,
Comprehensive immunization schedules, starting with measles.
rapid protocols for the treatment of childhood diarrhea with oral rehydration salts and zinc, and the provision of insecticide-treated bed nets in endemic malaria zones.
But crucially, Pillar 1 expands beyond just clinical medicine to include early learning activities.
Yes, cognitive stimulation and language development early in life build a neurodevelopmental buffer that provides a more equitable start.
And as that individual progresses through the life cycle, Pillar 1 expands into spatial and occupational exposures.
Town planning is a huge factor here. The text emphasizes proactive town planning in rural and informal urban areas.
Because if a city zones its high-polluting industries directly adjacent to low-income informal settlements, they are structurally engineering an asthma epidemic.
Exactly. It also points to the necessity of rural development to combat exclusionary policies that lead to landlessness.
Which is what drives that forced, desperate migration into urban slums.
Right. And then we hit the occupational determinant, meaningful employment.
The causal link between unemployment or precarious work and health inequity is profound. Meaningful, secure employment provides a predictable income,
Which is the basic prerequisite for accessing adequate nutrition, housing, and education. It also confers social status and self-esteem.
Conversely, the textbook highlights how indecent, precarious work or outright unemployment strips individuals of financial agency and severely damages that self-esteem.
And this psychological and economic desperation directly exposes populations to profound social ills. It increases the biological necessity to engage in high-risk survival behaviors.
Whether that's transactional sex, which alters the epidemiology of sexually transmitted infections, or engagement in illicit drug economies.
Safe, secure work is a fundamental public health intervention. There's no getting around it.
Which flows perfectly into Pillar 2. Tackle the inequitable distribution of power and resources. And I'll say, this section requires a massive paradigm shift for anyone trained in traditional clinical models.
It really does. As clinicians, we are trained to focus heavily on the patient's individual choices.
But the text explicitly states that a health equity paradigm requires us to stop blaming the victim.
It's a complete inversion of the traditional public health question. Historically, the field asked, how can we promote healthy behavior?
Which frames the issue as an individual moral failing. If someone is obese, they made bad dietary choices. If someone has lung disease, they chose to smoke.
But Pillar 2 demands we ask a different question. How can we target dangerous conditions and reorganize resource use and public policies to ensure healthy spaces?
So instead of lecturing a diabetic patient in a rural clinic about eating fresh vegetables, you investigate why their geographic area is a food desert.
Right, a food desert subsidized by agricultural policies that make highly processed, high glycemic foods the only affordable caloric option.
Instead of asking how to reduce disparities in disease distribution, we must ask how to eliminate differentials in the distribution of power and resources that actually shape those health outcomes.
It forces the clinician and the policymaker to acknowledge that historical, structural, and ideological factors, who owns the land, who controls the supply chains, who dictates the tax code, those are the things that play the ultimate role in shaping population health.
So let's look at how resource reorganization actually functions in practice. The text introduces the concept of the social wage. This is completely distinct from a financial wage paid by an employer.
Very distinct. The social wage is the scaffolding of social protection deployed across the full life cycle.
Because every human being is vulnerable to sudden, adverse life events.
Exactly. A catastrophic trauma, the onset of a chronic disability, a sudden economic recession leading to unemployment. The social wage acts as a shock absorber for all of that.
It comprises the public provision of basic utilities and services.
Heavily subsidized or free clean water, municipal sanitation, reliable electricity, affordable housing, universal education, and essentially free at the point of care health services.
Mechanically, a robust social wage decouples a person's basic survival from their immediate labor market value.
Yes. If you lose your job, you don't instantly lose your access to clean water and healthcare.
But the distribution of power isn't just a domestic issue governed by local tax codes. Pillar 2 scales all the way up to global market regulation. The text examines the TRIPS agreement,
The trade-related aspects of intellectual property rights.
managed by the World Trade Organization. This is where global trade policy collides violently with local epidemiology.
TRIPS is a vital case study in the tension between market incentives and health equity. The theoretical justification for strict intellectual property rights is that pharmaceutical companies require a monopoly to recoup the massive capital investment of drug discovery.
Sure, that's the market logic.
However, TRIPS mandated a minimum 20-year patent protection across all WTO member states.
Which, in the context of developing countries, meant that novel, life-saving medicines were legally blocked from generic manufacturing, keeping prices astronomically high.
The text details exactly how this played out in the late 1990s and early 2000s during the height of the HIV/AIDS pandemic.
Highly active antiretroviral therapy, or HAART, had transformed HIV from a death sentence to a manageable chronic condition in the West.
But because of patent protections under TRIPS, the cost of these ARVs was upwards of $10,000 to $15,000 per patient per year.
In sub-Saharan Africa, where the burden of disease was highest and per capita health spending was literally in the single or double digits, this price tag was an absolute insurmountable barrier.
Millions of people died because international trade law prioritized patent monopolies over access to essential medicines.
It was an engineered inequity on a global scale.
It was, and it required massive coordinated global advocacy from civil society, activist groups, and progressive governments to force the 2001 Doha Declaration,
Which affirmed that TRIPS should not prevent members from taking measures to protect public health. It opened the door for compulsory licensing and generic production of ARVs.
But the text warns that the fundamental structure of TRIPS remains largely intact today.
The unfettered market approach will continually exacerbate inequities, serving only those with the financial resources to participate in the market.
Unless responsible governments aggressively deploy market regulation for goods with major health impacts, and not just medicines, but also alcohol, tobacco, and ultra-processed foods.
And when we talk about the inequitable distribution of power, the text absolutely refuses to ignore gender equity and political empowerment.
Right. These aren't just social justice buzzwords. They are quantifiable determinants of morbidity and mortality.
Biologically and epidemiologically, gender inequities are devastating.
The text notes that harmful masculine norms, uneven power relationships, and unfair divisions of domestic and agricultural labor directly restrict women's access to health resources.
Because if a woman does not have financial autonomy or decision-making power within a household, she cannot authorize the expenditure required to seek emergency obstetric care.
Or even basic pediatric care for a sick child. This directly drives up maternal and under 5 mortality rates.
But because these power dynamics are socially generated, they are remediable.
Yes, they can be altered by challenging gender biases, reforming inheritance laws, and ensuring female political representation.
Which links directly to political empowerment. Exclusion from participatory democratic processes means a marginalized group has no leverage to demand their share of the social wage.
Governments must adopt legislation that guarantees citizens the actual right to participate in resource allocation decisions.
So that covers Pillar 1, daily living conditions, and Pillar 2, the distribution of power and resources. Pillar 3 is measure and understand the problem.
We need high-fidelity data to drive any of this policy.
But before we look at the specific indices used to map deprivation locally, we have to examine the macroeconomic data connecting national wealth to population health.
This is a crucial transition. It's really easy to assume that if a country just gets richer, its people will automatically get healthier.
But the data from the UC Atlas of Global Inequality, which is featured heavily in the chapter, reveals a much more complex, nonlinear reality. We need to dissect the wealth-health paradox and the $500 plateau.
The textbook analyzes a scatter plot graphing per capita government expenditure on health on the x-axis against life expectancy at birth on the y-axis.
The relationship follows a distinct parabolic curve,
Often referred to in health economics as the Preston curve. At the far left of the graph, among low-income countries, a very small increase in health expenditure generates a massive vertical leap in life expectancy.
Mechanically, what's happening there? Why is the return on investment so incredibly high right at the beginning?
Because those initial dollars are spent on the lowest hanging, highest impact public health fruits,
Establishing a clean water supply.
deploying basic childhood vaccines, and providing rudimentary sanitation. These inexpensive interventions eradicate the massive burden of infant and child mortality caused by infectious diarrheal and respiratory diseases.
And mathematically, when you stop babies from dying at age 1, the mathematical average of population life expectancy shoots up dramatically.
But as you move right along the x-axis, as the country gets wealthier and spends more per capita, the curve begins to flatten.
It flattens aggressively. The text identifies a specific plateau threshold.
Yes. Once a country reaches roughly $500 per capita in health expenditure, the massive gains in life expectancy practically vanish.
Spending an additional $5,000 or $8,000 per capita yields almost zero commensurate population level benefit in longevity.
You enter an era of diminishing marginal returns. Immense capital is poured into managing chronic diseases, highly specialized oncological treatments, and end-of-life care.
Which extends individual lives by months or maybe a few years, but barely moves the national average.
Exactly.
The plateau is fascinating, but what's even more revealing are the outliers that defy the curve entirely. Let's look at the paradox between the United States and Cuba.
This is a classic comparison.
The U.S. spends an astronomical amount per capita. They are way out on the far right of the x-axis. Yet the U.S. has a life expectancy comparable to, or even slightly lower than, Cuba, which spends a fraction of that amount and operates under severe economic constraints.
So how does a public health economist explain that? They explain it by looking beyond the total volume of resources and analyzing the actual distribution of those resources.
Averages mask internal disparities.
Right. And to quantify this, the text relies on the Gini coefficient.
Let's do a deep dive into the mechanics of the Gini coefficient, because it's a metric that every clinician should really understand when evaluating a population's risk profile.
The Gini coefficient is a measure of statistical dispersion intended to represent the income or wealth inequality within a nation. It is derived from the Lorenz curve.
Imagine a graph where the x-axis is the cumulative percentage of the population, from the poorest to the richest, and the y-axis is the cumulative percentage of national income they earn.
If wealth were distributed perfectly equally, the graph would be a straight 45-degree diagonal line, the line of perfect equality. 10% of the population holds 10% of the wealth. 50% holds 50%.
But in reality, the bottom 50% of a population never holds 50% of the wealth.
Never. So the actual curve, the Lorenz curve, sags below that straight diagonal line, creating a shape sort of like a drawn bow.
And the area between the straight line of perfect equality and the sagging Lorenz curve represents the degree of inequality.
Exactly. The Gini coefficient is simply the ratio of that area to the total triangular area under the line of equality.
So a Gini index of 0 means perfect equality.
And a Gini index of 100% or 1.0 means absolute inequality. One single person holds 100% of the nation's wealth and everyone else has 0.
Applying that back to our outliers.
Yeah.
The United States operates with a relatively high Gini coefficient, around 45% or higher, depending on the specific year measured. Wealth is highly concentrated.
And because health outcomes follow the social gradient, that high concentration of wealth means millions of Americans at the lower end of the income spectrum lack access to comprehensive preventive care and basic health insurance.
So the morbidity and early mortality generated by that significantly disadvantaged population drag the whole national life expectancy average down.
Yes, completely neutralizing the statistical impact of the extraordinary clinical excellence that is available to the wealthy at the top.
Conversely, Cuba operates with a Gini coefficient, closer to 30%. They have severe resource limitations, but they distribute what they have highly equitably.
Cuba prioritizes universal access to primary care. They maintain an exceptionally high doctor-to-patient ratio and embed preventative medicine deeply within the community structure.
By ensuring the baseline interventions reach 100% of the population, they maximize their population-level longevity.
Essentially proving that equitable distribution is a more powerful determinant of national life expectancy than aggregate GDP.
The text provides another stark warning with South Africa. In the data cited, South Africa had a Gini coefficient of 65%.
One of the highest levels of inequality on the planet.
A direct legacy of the spatial and economic engineering of apartheid.
Consequently, despite having a sophisticated private medical sector and a larger economy than many surrounding sub-Saharan nations, its national life expectancy indicators are incredibly poor.
The wealth is just too highly concentrated to confer a population-level biological benefit.
The takeaway from Section 3 is definitive. Economic growth is not a panacea. If the wealth generated by a growing economy is captured entirely by the top decile of the population, public health indicators will stagnate.
To improve population health, a government must actively map out the disparities and deliberately target resources to the bottom quintiles.
Which brings us to the actual mechanics of Pillar 3, mapping the terrain.
If you are a health minister, you can't just guess where the most vulnerable people live. You need a highly sensitive, localized radar system.
The text outlines how systems quantify structural disadvantage, dividing the approach into individual measures versus geographic, area-based measures.
Individual measures are the most intuitive, right? We collect data on a person's specific income, their highest level of education attained, or their occupational class.
This allows for highly granular analysis, comparing the precise health outcomes of individuals in the top 20% of income against those in the bottom 20%.
However, from a practical surveillance standpoint in developing nations, acquiring reliable, updated individual data for millions of people is tough.
Especially in regions with massive informal economies where income isn't reported on tax returns, it's logistically impossible.
That logistical barrier makes geographic or area-based measures absolutely essential. Instead of analyzing the individual, you analyze the aggregate characteristics of the environment they live in.
You apply indicators to a defined spatial district, and the textbook provides a masterclass in how this is operationalized through South Africa's deprivation index.
South Africa needed a mechanism to objectively chart relative deprivation across all of its health districts to allocate resources efficiently.
The Health Systems Trust, an NGO, built this deprivation index utilizing demographic and socioeconomic data harvested from national household surveys.
We really have to look at the exact variables they selected because this list is the literal anatomy of structural vulnerability. They didn't just measure income.
No, they looked at the proportion of children under 5 because a high ratio indicates a high dependency burden on adults.
The proportion of female-headed households, which historically correlate with lower earning potential and higher vulnerability.
Households where the head has no formal education, the proportion of the working-age population that is unemployed.
They also heavily weighted environmental and infrastructural variables.
Right, the proportion of people living in traditional dwellings, in formal shacks or tents.
Households lacking piped water, forcing reliance on contaminated surface water.
Households relying on bucket toilets, pit latrines, or lacking sanitation entirely. These are massive drivers of enteric enteropathy and cyclical diarrheal disease,
And finally, households lacking access to electricity or gas, meaning they rely on burning biomass indoors for cooking and lighting.
which drives high rates of chronic obstructive pulmonary disease and pediatric acute respiratory infections.
The biological consequences of those living conditions are obvious. But the statistical challenge here is immense. You have all these overlapping vectors of misery. You cannot simply add a lack of a toilet to a lack of formal education using basic arithmetic.
You can't.
So how do you turn this complex web of variables into a single operational metric that a government can actually use to dictate a budget?
They utilize a sophisticated statistical technique called principal component analysis, or PCA.
PCA is essentially a dimensionality reduction algorithm.
Yes. In public health surveillance, you often have a data set with numerous variables that are highly correlated. For instance, a household with no piped water is also highly likely to lack electricity and have a low level of education.
They are all measuring different facets of the exact same underlying unobserved phenomenon. In this case, structural deprivation.
So conceptually, instead of trying to juggle 10 different maps showing 10 different problems, PCA finds the common denominator.
Mathematically, PCA analyzes the covariance matrix of all these variables. It identifies the principal components.
The new orthogonal axes that capture the maximum amount of variance within the data.
By extracting the first principal component, the statisticians were able to distill all those overlapping, messy, real-world struggles into a single, standardized composite score for every single district.
And the practical application of that single score is where the upstream engineering occurs. By generating that PCA score, the South African government could rank all 52 districts into socioeconomic quintiles.
From the most affluent 20% to the most deprived 20%.
This is a revolutionary capability for health financing. It allows for a shift from a blind equality approach to a targeted equity approach.
Because if you distribute your national health budget equally per capita across all 52 districts, you are reinforcing the status quo.
The poorest districts have a much higher baseline burden of disease and require more resources just to reach a baseline standard of care.
By utilizing the deprivation index, the central government can actively weight their budget allocations, deliberately funneling a disproportionately higher percentage of financial and human resources into the districts in the lowest quintile.
You map the vulnerability, and then you heavily bias your resource distribution to neutralize it.
But what is the actual vehicle for delivering those resources? The consensus in the text points entirely to one specific structural intervention: universal coverage.
Often operationalized via National Health Insurance, or NHI. The World Health Report in 2011 emphatically urged member states to transition toward universal coverage.
Whether you call it NHI or UC, the functional definition is a health financing system that provides universal access to essential, high-quality services while systematically eliminating financial barriers at the point of care.
Specifically, catastrophic out-of-pocket payments. The textbook is clear that this is not merely an economic mechanism. It is a policy tool rooted deeply in the human rights philosophy we discussed earlier. It is the practical realization of social justice.
The text dedicates a significant portion of the chapter to a comparative analysis of how different developing nations are attempting this massive transition. It's a real spectrum of success and struggle.
Let's return to South Africa as our first case study. They are a middle-income country, the economic powerhouse of the continent. Yet they are trying to dismantle a two-tier health system heavily scarred by their political history.
South Africa's current architecture is highly inequitable. There is a deeply resourced, highly capitalized private sector that serves a small, affluent minority.
Largely funded through private medical schemes.
Parallel to this is a chronically under-resourced, overburdened public sector that serves the vast majority of the population, funded through general taxation.
To rectify this, the government proposed an ambitious, phased 14-year rollout of a national health insurance plan designed to pool the risk and cross-subsidize care across the entire population.
But the textbook is unflinching in its analysis of the barriers to this NHI. It doesn't just point to a lack of aggregate funding.
The fiscal space is a constraint, certainly, especially with high national unemployment restricting the tax base. However, the text identifies a much deeper structural pathology threatening the NHI.
A debilitated and, in some provinces, completely dysfunctional state capability.
You cannot implement a highly complex nationalized purchaser-provider split if the underlying public sector infrastructure is paralyzed by a severe shortage of specialized clinical skills, catastrophic drops in staff morale, and profound leadership and managerial flaws at the provincial and district levels.
Furthermore, the private sector's hospital and specialist costs have inflated massively, creating fierce resistance to integration.
South Africa perfectly illustrates that policy ambition is totally irrelevant if the state lacks the bureaucratic and clinical capacity to execute it.
Now, maintaining our strict commitment to neutrality, we must analyze the text's case study of pre-conflict Syria.
The chapter uses Syria not to discuss the subsequent war, but to examine the highly specific and often devastating epidemiological impacts of macroeconomic structural reforms.
The data presented is a stark warning. Historically, Syria operated a centrally planned, top-down state economy with a heavy, publicly funded emphasis on primary health care.
And the epidemiological data proves that this central planning was highly effective at achieving public health goals. Over a 30-year period, they achieved massive reductions in mortality.
The infant mortality rate plummeted from 132 per 1,000 live births down to just 14.
Maternal mortality saw similarly impressive, sustained declines. They had built a robust, equitable baseline.
But the architecture shifted. In their 10th five-year plan, spanning from 2006 to 2010, the government, with backing and guidance from Western entities, including the European Union, initiated a package of deep economic liberalization policies.
The explicit goal of these neoliberal reforms was to commercialize and liberalize the health sector.
The text documents how these policies actively dismantled the existing universal coverage frameworks.
They introduced new, fragmented health insurance schemes and, crucially, instituted fee-for-service charges at public hospitals and clinics that had previously been free.
And what was the immediate public health mechanism of action?
The introduction of user fees instantly erected a financial barrier at the point of care. Out-of-pocket expenses spiked. Vulnerable populations, particularly those in rural or lower-income brackets, could no longer afford basic primary health care or maternal services.
The textbook provides evidence that these market reform policies rapidly began to reverse the hard-won public health gains of the previous 3 decades.
Infant and maternal mortality declines completely stalled and threatened to regress. It reinforced the rich-poor divide, drastically widened health inequities, and fueled immense underlying social discontent.
It is a textbook demonstration of how dismantling universal protections in favor of market liberalization can have immediate, lethal consequences for a population.
It perfectly illustrates that health equity is fragile. It can be undone by a single shift in tax or tariff policy.
And let's contrast that with the text's most prominent success story, Thailand.
Thailand's rollout of their Universal Coverage Scheme, or UCS, in 2002 is one of the most remarkable feats of health systems engineering in the modern era.
What makes it so incredible is the macroeconomic context. They didn't launch this during an economic boom.
No, they rolled out this massively ambitious, highly expensive social protection scheme directly in the wake of the devastating 1997 Asian financial crisis.
Their per capita income was relatively modest, and external macroeconomic advisors were highly critical and deeply skeptical of its financial viability. Yet they executed it with blistering speed.
They succeeded because they engineered the financing and governance structures brilliantly. First, they opted for a predominantly tax-financed scheme,
Pooling the risk across the entire national tax base, rather than relying solely on formal payroll deductions.
which is vital in a country with a large informal agricultural sector. Initially, they instituted a nominal copayment of 30 baht, roughly 70 US cents per clinic visit.
But remarkably, by 2006, they recognized that even this tiny fee was a barrier for the ultra-poor, and they abolished it entirely, making the essential package completely free at the point of care.
Second, they didn't just offer open-ended funding for any procedure a doctor wanted to perform. They instituted a comprehensive benefits package with a ruthless prioritization of primary care, prevention, and high-impact interventions.
And they controlled costs by utilizing a fixed budget with capitation payments.
Capitation is a crucial concept. Instead of a fee-for-service model where a hospital bills the government for every single pill prescribed or test ordered.
Which incentivizes massive overtreatment and budget blowouts.
Exactly. The Thai system paid a flat, fixed rate per citizen enrolled in a specific district's health network. Suddenly, the financial incentive for the healthcare provider flipped.
They were incentivized to keep their enrolled population as healthy as possible through cheap, preventive primary care, so they wouldn't have to spend their fixed capitation budget on expensive downstream hospitalizations.
But the textbook identifies one specific structural innovation as the ultimate key to Thailand's success: the separation of the purchaser and the provider.
This is the masterstroke of governance. Thailand created the National Health Security Office, the NHSO.
The NHSO acted as the sole purchaser of health services on behalf of the Thai citizens. They held the budget.
The Ministry of Public Health, which ran the hospitals and clinics, remained the provider.
By separating the two, the ministry no longer controlled its own funding stream. It had to meet the strict quality metrics and cost controls dictated by the NHSO to receive its capitation payments.
This forced massive efficiencies and accountability into the system.
The outcome data is phenomenal. By the end of 2001, just before full rollout, the scheme already covered 75% of the Thai population.
That's 47 million people, 18 million of whom had previously been entirely uninsured and highly vulnerable.
And the most important metric the text highlights is medical impoverishment. This measures the incidence of non-poor households being driven beneath the poverty line, specifically by catastrophic out-of-pocket medical bills.
Before the UCS launched in 2000, medical impoverishment in Thailand was at 2.71%. By 2009, it had plummeted to 0.49%.
The scheme virtually eliminated the risk of a medical diagnosis causing financial ruin.
The chapter also outlines significant strides in Latin America, focusing on Mexico and Brazil.
Mexico provides a fascinating model of iterative expansion. They recognize that their traditional labor-based social security system fundamentally excluded the massive portion of their population working in the informal economy.
So in 2003, they engineered Seguro Popular.
The mechanics of Seguro Popular were designed specifically to target those excluded populations. It wasn't tied to formal employment.
It was funded through a combination of federal and state subsidies, with sliding scale premiums based on socioeconomic status, heavily subsidizing the poorest deciles.
It provided a guaranteed package of essential interventions and specifically targeted catastrophic health expenditures.
And critically, it was often integrated with their conditional cash transfer programs like Opportunidades, where families received financial stipends conditional upon attending preventive health checkups and keeping children in school.
Directly attacking multiple social determinants simultaneously. The result was the provision of healthcare access to over 50 million previously excluded Mexicans.
Treating health as a universal right based on citizenship, rather than a privilege tied to formal labor contracts.
And Brazil's approach was even more structurally profound. The creation of their Unified Health System, or SUS, was the direct result of a massive grassroots civil society mobilization following the end of their military dictatorship.
They actually hardwired health equity into the foundation of the state. The 1988 Brazilian Constitution explicitly enshrined health as a universal human right and a duty of the state.
The SUS is built on deep decentralization, pushing the management and delivery of healthcare down to the municipal level, ensuring local community participation and accountability.
They integrated this heavily with the family health strategy, deploying massive teams of community health workers directly into vulnerable neighborhoods.
And because this health reform was integrated with broader macroeconomic social protection policies like massive poverty reduction strategies and minimum wage expansions, the synergistic effect was staggering.
Between 2004 and 2009, Brazil saw its poverty rate fall from 20% down to just 7%, achieving drastic reductions in both regional and socioeconomic health inequalities.
South Africa's struggle, Syria's cautionary tale, and the massive successes of Thailand, Mexico, and Brazil all point to the same absolute conclusion. Equity does not passively emerge as a byproduct of a rising GDP.
It must be deliberately, aggressively, and structurally designed.
Which leads us to the final analytical section of the chapter, Section 6, the new Great Transition.
The question is, if the blueprint is so clear, what is the current state of this global movement? Are we actually executing effective intersectoral action?
The text provides a deeply sobering reality check on our current scientific rigor in this field. It cites a systematic review that attempted to evaluate the evidence base for intersectoral actions designed to promote health equity.
The researchers started with a massive pool of roughly 10,000 selected articles detailing various social determinant interventions.
But when they applied strict, rigorous appraisal criteria to evaluate the actual measurable impact of these interventions, the pool evaporated.
Out of 10,000 articles, Only 17 met the inclusion criteria for rigorous evaluation.
That is an astonishing indictment of the literature. 10,000 descriptive papers, but only 17 that actually proved an intervention worked.
And even among those 17 robust studies, the evaluation of their impact was highly mixed, demonstrating only moderate to sometimes no measurable effect on health equity.
The conclusion the textbook draws is blunt. The field of social determinants is currently far too heavily weighted toward description. We have become exceptionally good at admiring the problem, at mapping the deprivation, and at theorizing the injustice.
But there's a severe critical deficit of high-quality, rigorously evaluated evidence regarding actual implementable interventions. We urgently need to shift from descriptive epidemiology to interventional, measurable action.
Despite the lack of academic rigor in the literature, the political momentum is coalescing. The text highlights a watershed moment, the 2012 UN General Assembly,
where a resolution was unanimously adopted, urging all member states to urgently transition toward providing universal access to affordable, quality health care, explicitly recognizing that expanding social protection is a necessary prerequisite.
And this is where the textbook brings our overarching paradigm to its logical conclusion. It frames this modern push for universal coverage not just as a policy trend, but as the third massive historical epoch in public health.
Think of it sequentially. The first epoch, spanning the 18th and 19th centuries, was the sanitary transition.
We engineered our physical environment. We built the aqueducts, the municipal sewers, and the clean water systems, drastically cutting enteric diseases.
The second epoch, dominating the 20th century, was the biological transition. We engineered our immunological environment.
We developed and globally deployed massive immunization campaigns, eradicating smallpox and marginalizing polio and measles.
And now, in the 21st century, we are attempting the great transition, the engineering of our social and financial systems.
It is the systemic provision of universal care by fundamentally altering how the risk of illness is financed, how health systems are governed, and how power is distributed. It is the final, most complex phase of redesigning the riverbanks.
The sanitary, the biological, and the social transitions. That framework perfectly clarifies the trajectory of the entire discipline.
It really does.
Now, to push the analysis just one step beyond the text, let's consider a distal variable that wasn't fully materialized when the WHO Commission formed. The text demonstrates how historical shifts in labor, like the brutal industrialization Edwin Chadwick measured, created massive mortality gaps.
Looking forward, how will the impending AI revolution and the transition to a borderless, highly fragmented gig economy impact the social wage?
If employment in developing nations becomes increasingly informal, decoupled from physical geography, and stripped of traditional national labor protections, how will systems like Thailand's continue to capture the tax base required to fund universal coverage?
Are we fortifying our health infrastructure for the realities of the next industrial revolution, or are we just finally catching up to the last one?
That is precisely the kind of complex intersectoral forecasting the next generation of public health leadership must engage in. The tax base will shift, the exposures will shift, and the architecture must adapt proactively.
Let's ensure the foundational concepts from today are locked in. I will present 5 rapid single best answer questions based directly on the mechanics we've analyzed.
Take a few seconds after each prompt to actively recall the answer before we confirm it.
Question 1. What is the fundamental operational difference between health inequality and health inequity as defined by the WHO?
You can review the introduction section for the philosophical underpinnings of this distinction. Take a moment to think about your answer.
The answer is inequality is a descriptive, measurable difference in health status, while inequity refers specifically to differences that are avoidable, unfair, and remediable through systemic action.
Question 2. In the context of plotting national wealth against life expectancy, at roughly what per capita healthcare spending level do life expectancy gains begin to experience severe diminishing marginal returns?
Reference the section Tackle the Inequitable Distribution of Resources. Do you have the number?
The answer is approximately $500 per capita. After this plateau, the equitable distribution of resources becomes far more vital than the aggregate total.
Question 3. In Thailand's universal coverage scheme implemented in 2002, what specific governance mechanism was crucial for controlling costs and ensuring quality?
This is detailed in the section Thailand Transforming Towards Universal Access. Lock in your answer.
The answer is the structural separation of the purchaser, the newly created NHSO, from the provider, the Ministry of Public Health, coupled with the use of fixed capitation budgets rather than fee-for-service models.
Question 4. What specific dimensionality reduction statistical technique was utilized to combine overlapping socioeconomic variables into a single composite score for South Africa's deprivation index?
This is a tricky one, found in the section Measure and Understand the Problem. Think about the acronym.
The answer is Principal Component Analysis, or PCA.
Question 5. According to the overarching framework presented in the text, the current global push for universal coverage represents the third great transition in public health, following which two historical transitions.
You can review the section Global Endorsement Towards a New Great Transition. What were the first two?
The answer is the sanitary transition of the 19th century engineering physical environments and the biological transition of the 20th century engineering immunity via vaccines.
This concludes our analysis of Chapter 9. Thank you for engaging with the architecture of equity. Here are the details of this episode.
Reducing health inequalities in developing countries. Byline, closing the survival gap from structural disadvantage to strategic reform. Episode description. In many developing countries, health inequalities are both stark and visible. Maternal mortality, child survival, infectious disease burden, and malnutrition disproportionately affect the poorest, rural populations, and marginalized groups. This chapter moves from describing inequality to confronting how it can be reduced. It examines the structural drivers of disparity: poverty, weak infrastructure, limited education, gender inequity, political instability, and underfunded health systems. We explore strategies that have demonstrated measurable impact: expansion of primary health care, immunization campaigns, conditional cash transfers, community health worker programs, improved water and sanitation systems, and targeted maternal and child health interventions. We explore strategies that have demonstrated measurable impact. The chapter also discusses governance and financing, domestic resource mobilization, fair taxation, donor alignment, and accountability mechanisms determine whether inequality reduction efforts are sustained or fragmented. We explore strategies that have demonstrated measurable impact. Importantly, reducing inequality requires deliberate prioritization of the most disadvantaged, not simply expanding services in aggregate. We explore strategies that have demonstrated measurable impact. Equity does not emerge automatically from growth. It requires design. We explore strategies that have demonstrated measurable impact. We explore strategies that have demonstrated measurable impact. Key takeaways. We explore strategies that have demonstrated measurable impact. Health inequalities in developing countries are often extreme and visible. We explore strategies that have demonstrated measurable impact. Rural, poor, and marginalized populations bear disproportionate burdens. We explore strategies that have demonstrated measurable impact. Strengthening primary health care is central to equity improvement. We explore strategies that have demonstrated measurable impact. Community-based interventions can bridge geographic and social gaps. We explore strategies that have demonstrated measurable impact. Social protection policies can indirectly improve health outcomes. We explore strategies that have demonstrated measurable impact. Governance quality strongly influences program success. We explore strategies that have demonstrated measurable impact. Targeted maternal and child health strategies reduce mortality gaps. We explore strategies that have demonstrated measurable impact. Sustainable progress requires long-term financing commitments.